diploma in marketing management and also a fellowship diploma in dispensing optician with over 18 years of experience in the optometry field, including 9 years in academics. Ms. Kavitha ma'am brings a wealth of clinical expertise and teaching excellence. So she has been a valued part of Divai Patel family since June 2022. So serving as a program coordinator for the department. So we are delighted to have her with us today.
Thank you, ma'am. Thank you so much for this lovely introduction.
Yes, ma'am. Welcome
I
you,
hope
ma'am.
we will have a good session today.
Yes, ma'am. So over to Ms. Daisy Colaco for who is the presenter for today's session. So Daisy, so you can start off with your presentation.
For joining the session.
इधर ही बैठना प्लीज
Daisy, can we start?
Yes, ma'am. So, good afternoon, everyone. My name is Daisy Colaco. I'm an intern in Bachelor's in Optometry at DY Patil Deemed to be University. Today, my topic for case presentation is diabetic retinopathy, where we'll see the exact how moderate to severe diabetic retinopathy is happening. So on 4th of September 2025, a 56-year-old male patient presented with complaints of gradually painless diminution of vision for distant and near in both eyes since 2 years, but not associated with any other symptoms. So last month, a patient came to our OPD and he was complaining about gradually painless diminution of vision, both in distance and near since 2 years. So we asked the patient, did he visited any hospital prior coming to our hospital? He said that he did not go to any other hospital and there were no associated symptoms as such. History of present illness, his vision decreased slowly and progressively. There was no sudden loss of vision or metamorphopsia, no history of trauma, and he was only complaining about the occasional floaters. Past medical history, he was a known diabetic for 12 years and was on medication, even known case of hypertension for 10 years and was on medication. There was no history of cardiac disease, no history of ocular trauma or surgery. Despite of being on medication since 12 years, this patient's diabetes, the sugar level was not in control. Family history was insignificant. Social history, he was a patient is non-smoker and non-alcoholic. Allergic history, patient does not know if he is an allergic to any topical or systemic medication because he haven't done any allergic test before that he is allergic to any eye drops or any medications. Then let's move on to ocular examination, that is the visual acuity. The unaided vision for right eye was 636 parts and left eye was 636. Then pinhole vision improved to 618 both eyes, and unaided near vision was N36 for both eyes. On torchlight examination, we got to know that the patient is orthophoric. Pupil examination shows no RAPD, EOM full in both eyes, no deviation of eye on cover or uncover test, no abnormality of visual field on confrontation test as such. On slit line examination, the anterior segment showed lids, conjunctiva, cornea normal, and the anterior chamber normal depth. Iris pattern was normal. Lens showed early lenticular changes in both eyes. On applanation tonometry, the intraocular pressure for both eyes was 18 mmHg at 10 am. In posterior segment examination, the right eye showed that there were microaneurysms, multiple dots and blot hemorrhages, multiple hard exudates, and for left eye, it showed microaneurysms, few dot and blot hemorrhages, few hard exudates. So after this all slit lamp examination, the patient was advised for OCT and fundus scanning. So here's a colored picture of the fundus where we can see that there are hard exudates, that is yellow waxy lesion, and dot and blot hemorrhages with microaneurysms. Here we can see dot and blot hemorrhages with hard exudates. This is of right eye, and same for the left eye. But in left eye, there were fewer microaneurysms and dot and blot hemorrhages with hard exudates. The fundus and OCT finding shows diabetic retinopathy changes, and OCT reveals clinically significant macular edema. Here's the OCT scannings for right eye and left eye. In right eye, we can see RP changes with the hard exudates and macular edema. Same for the left eye. But the right eye had more hard exudates and microaneurysms. Here's a more well-defined picture of the right eye OCT image. We can see there are hard exudates and macular edema. Same for the left eye. Here are some hard exudates with macular edema and RP changes. So after all this fundus examination and after getting all the tests done with all the scannings, we came to a point where the diagnosis was moderate to severe non-proliferative diabetic retinopathy with clinical significant macular edema in both eyes. Later, the patient before giving any plan of management and treatment, the patient was asked to get his general and systemic investigation done. That is BPs, FBSC, PPBSC, RBSC, HbA1c, and lipid profile test. Management and plan, the ocular management was intravitreal anti-VEGF injection and regular follow-up after every 3 months. And systemic management was strict glycemic control, that is HbA1c should be less than 7%, and blood pressure should be in control with lipid control and regular physician follow-up. After 1 month post-examination, the 1 month post-injection, patient was asked to control his glycemic level, and after that, he was asked to come to the hospital for a follow-up, wherein we saw that the patient's report showed some mild improvement in the vision, and there was no pain or redness post-procedure. The objective findings showed that the visual acuity, unaided vision, which was prior 636 in both eyes, improved to right eye 618 and left eye 612, and pinhole vision improved to right eye 612 and left eye 69. The fundus examination showed post 1 month injection reduction in macular edema, fewer microaneurysms visible, and hard exudates partially absorbed. Then the plan for next second post injection was done after 2 months, and patient was suggested for anti-VEGF dose after 4 weeks. Thank you.
Okay, Daisy, this was a very common case. Like I think in OPD, everyday OPD, we are finding this diabetic patients very frequently, right?
Yeah. Yes.
We all are aware how our country or globally diabetes mellitus has become a endangering thing. It's a major concern. So if you go to see the prevalence rate, even in 2019, the prevalence rate was 9.3% to the population of 463 million people. And now it has projected to 10.9%, that is for 700 million people. And this has been expected like it will affect 10.9% of our population by 2045. So it's a major concern, and this is something what we see very commonly in OPDs. So I would like to know, like as an optometrist, what would be your role? Like how would you manage a patient? Just tell me, like in terms of an optometrist, what's your role?
Okay. Okay, ma'am. So in terms of optometrist, first of all, I would take patient's proper history, which is mandatory to ask the patient about his blood sugar sugar levels before fasting and after fasting. It is very important for a diabetic patient because diabetes is a disease wherein the blood sugar level increases and can lead to diabetic retinopathy. And second is I'll do the primary examinations, that is vision taking and then refractions. Later on, I will do the patient's OCT scannings and fundus photo. Even sometimes we often advise patient for FFA, that is fundus fluorescent angiography, wherein we can see the proper symptoms of diabetic retinopathy, that is microaneurysms, hard exudates, and many more other symptoms. So, because it is very important for us to know about the patient, whether the patient's blood sugar levels were controlled, and most importantly, HbA1c, because the HbA1c, wherein the hemoglobin, the proteins which go and stuck to the hemoglobin, and it is stuck around, we need to check like for how long it was stuck. And that is why we need to track the 3 months HbA1c, and it should be less than 5 to 6%.
Can anyone answer me, like just by doing the preliminary examination, can you suspect a patient for diabetes or diabetic retinopathy just by doing some refraction or some preliminary examination? Has anyone faced it, or anyone who can just comment on it, like this made me suspect if the patient is diabetic or diabetic retinopathy? We all do refraction, right? We all are doing a first history, and after that we are doing refraction. At least by doing a refraction or vision analysis, any moment that you have realized that this can be leading to diabetes or maybe some uncontrolled sugar level, anything that you have noticed which is alarming, like we should go for further investigation. If anybody can answer, like I really want to know if you all understand this. And this is very important as an optometrist to understand when your refraction shows some variations and which is very alarming. Anyone who wants to discuss about this?
Dear participants, you can use this forum to clear out your doubts, and also you can be active. If you
Yeah.
are unable to unmute and talk, also you can post your messages in the chat box.
Yeah, this is just because you all are interns, and I believe you all are facing these patients, this kind of cases every day. Or I must say, almost at least in a week, you might be getting these cases. So you might have some experience, or you might have something to share. Like you found a patient with this kind of refraction, and later on turned out to be something else. Anything like that? No? Okay, this is very important, which I would like to highlight over here when we are talking about diabetic retinopathy, or if you're talking about diabetes and role of an optometrist. It's very important to understand we are the first person who can actually judge it. Okay, so it starts from the refraction, or it starts from the am I audible?
Yes, ma'am. Yes, ma'am. You're audible.
Yeah. So yeah, it starts from the vision taking. Okay. So I'll tell you from some cases what I have seen personally. So patient comes with a prescription. I mean, like comes for a general checkup. We prescribe. Maybe sometime you miss out on their sugar levels, or you're not asking for it, and then suddenly after a few weeks or days, a patient comes back with a different scenario of refraction, or there is some myopic shift, or there's some hyperopic shift in their refraction. Okay, so this is one thing where we have to be very particular regarding the history when you're taking their personal history, their systemic history, their family history, to check about their sugar levels, wherein HbA1c is very important, that is glycated hemoglobin. Okay, in glycated hemoglobin, it typically tells you the lifespan of a red blood cell, which is chemically linked to glucose. Okay, so when you take these readings, it will tell you whether the glycated levels are high, or it will tell you the value. Like suppose if the value is greater than 6, it will tell you if it's a pre-diabetic patient. If the values are greater than 7, it would tell you the patient is diabetic. Okay, and if it is something more than that, it will tell you the patient is alarmingly diabetic, which is not under control. Okay, so when you get such patients, you will always see their refraction would be very fluctuating. Okay, so whenever there's a patient, when a patient is coming and suddenly you might even face a patient saying that suddenly the near vision has become clear without glasses and the distance vision is affected. That's a typical myopic shift which you get in a non-proliferative diabetic retinopathy. So the mechanism behind it is there's a high blood glucose, and then there would be increased glucose in the aqueous humor. It will diffuse into the lens. It will get converted to the sorbitol and via your aldose reductase. And then there would be some osmotic swelling in the lens, which tends to increase the curvature and refractive index of your lens. What this results to? This results to a myopic shift, which is a nearsightedness, right? So now the patient will start complaining. There is a sudden blurring for distance vision, and suddenly the patient is feeling better without glasses for near. So this is something which is first thing that you notice. This is very much reversible once the sugar is under control. So whenever you get a patient like that, you are not supposed to prescribe. Now, at the same time, when there is hypoglycemia, that is, there is a rapid glycemic correction. Okay, when the high glucose levels are normalized rapidly, the lens will lose its water and it will start flattening slightly, which will result into hypermetropia. Now, again, there would be a shift. Now, the patient will start feeling difficulty in near, and patient would rather not complain much about distance. Okay, again, this is temporary. Again, it depends upon how much the sugar levels are being, or the glucose levels are being controlled by the patient. So two things that you have to always remember. If you find a myopic shift, you have to understand there is hyperglycemia in that patient. Or if you're finding a sudden hyperopic, or if the patient was already a hyperopic patient and a more hypermetropia being added to it, or you're finding an hypermetropic shift, you should see to it that patient is hypoglycemic, or there is some rapid glycemic correction happening, maybe alteration in medicines or lifestyle or something like that. Also, one more thing, what as an optometrist you have to look for is the quality of the vision. Or like for example, if the patient ends up with a macular edema. Okay, so what will happen in macular edema, that is a diabetic macular edema, this will cause retinal thickening at the fovea. And this thickening will affect your vision. The vision would be distorted, or the central vision would be blurred. So the patient would complain, would have this metamorphopsia. Patient might complain about halos or distorted vision. So you have to do your Amslers, you need to regulate, or you need to check whether the macular edema is subsiding or not. In these cases, you are not supposed to prescribe glasses, because this scenario can change over a period of time, and patient might get a reversible, might go into a refractive state where it would be reversible. So it's a concern that in such conditions do not prescribe. Another one more thing which is important, what you have to emphasize on is if there is any index myopia developing, or there is any kind of cataract development happening. Because when there is a chronic hyperglycemia, that will lead to sorbitol induced lens opacities, which is called as diabetic cataract. Okay, which causes index myopia due to the increased lens density and the refractive index changes. So you need to again monitor for this cataract development, and this can be very rapid also. Okay, so in short, if you are getting a patient and the clinical implications for refraction would be Either the patient is having an uncontrolled blood sugar, check for myopic shift. If the patient is having a rapid glucose correction, look for an hypermetropic shift. If the patient is having a macular edema, look for fluctuation in vision. And if the patient is having cataract development, look for index myopia or irregular refraction. Okay, and if we are very clear with these things, it will help us to avoid major errors, like by mistake, if you will prescribe to this patient, they might end up making glasses and have wrong prescriptions, or they might come back with a complaint that initially the glasses were good but now it is not good, right? So this is one very important thing as an optometrist you should always check for. And of course, the follow-ups are very important. You have to always check the patient. Even before prescribing, you need to check with their HbA1c, their fasting and PP reports. And any associated, because anything related to their metabolic changes or microvascular changes, the patient might end up having diabetic retinopathy. So you need to check all these things. And for that, you need to do the supportive investigations, right? So you have systemic investigations as well as you have ocular investigations. In systemic investigations, you are supposed to do the sugar test, the check for the glycemic variations. You need to check for lipid profile, because dyslipidemia increases the risk of hard exudates and macular edema. So you need to check, need to ask your patient to get the reports. You need to check for any renal function test, okay, because even detecting diabetic nephropathy is also like they share the same, somewhat same microvascular pathology. So you need to check for that. You need to check for blood pressure measurements, because hypertension also accelerates diabetic retinopathy progression. Also check for your complete blood count, because you want to rule out whether the patient is anemic or not. Because if the patient is anemic, again, it will aggravate ischemic damages, which again adds on to your condition in diabetic retinopathy. So these were the systemic disease, whatever you're going to, the systemic investigations. And also to add on to the ocular investigations that you should do a complete refraction, a complete fundus examination. You need to do fundus photography. You need to do OCT test to understand macular edema. And also, end of the day, you need to have a proper follow-up for their visual acuity assessment. And also, this can lead to secondary glaucomas, so always keep monitoring their intraocular pressures too. Okay, so I think even it's very clear how to, everyone must be aware like how to understand if it is a moderate NDPR or NPDR, or if it is a severe one. So anybody can, like if anyone wants to just add on to their experience in diagnosing if it was a moderate or a severe NPDR. Okay, even you can have a proper systemic follow-ups, systematically you can have this appointment. If it's a mild NPDR, call them every 6 monthly to 12 months. Or if it's a moderate one, call them every 3 to 6 months. Or if it is a severe one, then you have to call the patient every 2 to 3 months. And keep checking whether the patient is landing in with macular edema or any ischemia suspected. Then depending on that, you need to frequently call the patients for the further treatment. Anyone wants to ask anything?
Students, if you want to clarify any doubts, you can use this opportunity. So ma'am has clearly explained about diabetic retinopathy and its severity, how it is going to be progressive, and it is a very common case that we see in our clinics day to day in our life, and how diabetes is going to affect our eyes also. So if you want to add on to your experience, or if you have any confusion in identifying the diagnosis, then you can please post the questions here. If all are clear, then we can we have a thumbs up? If you are clear on the topics, and if you all no doubts, then can we have a thumbs up? Yes. Okay. Thank you then. So if you have any questions, you can please message me. Then I'll get back with ma'am and I'll let you know. Thank you, Ms. Kavitha ma'am, for the wonderful session.
Thank you so much.
It was really an expertly steering session today, and we had a lot of take-home messages, and very insightful inputs have been also been given. So thank you for giving clarity and depth about the topic into the session, and in a very understandable way to the students as well. So thank you for your time, dedication, and your valuable contribution, ma'am.
Thank you so much for giving me this opportunity.
Thank you.
Thank you, Daisy, for presenting.
Thank you, Daisy. It was a wonderful presentation as well, ma'am. So looking forward with many more presentations with you. So
Of course, of course.
thank you, ma'am. Thank you for taking your time, and thank all interns and externs who have joined today. So we will meet you all in the next Friday class sessions. And before that, as I have already posted in the group, so there is a conference coming up, ISP Tech 2025, which is in collaboration with Dr. Agarwal's Institute of Optometry and Layla College. So it's going to be a kind of eye and a engineering concept together. So we can start registering to it. Those who are in Chennai, you can visit the conference in person. Those who are outside Chennai, you can the online registrations are open, so you can start registering. I have posted the group in interns externs group, and as well as I have posted the registration link also. So if you have any doubts, please feel free to reach out to us, so we will help you out with registrations. So if you have any other doubts, we do have workshops conducted in math lab and other topics. So we will keep posting those information also in the groups. So if you have any doubts, please feel free to reach out to us, and if you are interested also, you can please contact me for that.
I would like to thank my ma'am, my professor, Ms. Kavitha Palleri, for giving me this opportunity to present this case. And I would also like to thank Dr. Agarwal's Eye Institute for giving me this chance to present a case in front of everyone. Thank you.
Yes. Thank you, Daisy. Thank you, Daisy. Thank you, ma'am. So we'll meet on in next sessions, ma'am.
Okay, sure. Bye.
Thank you. Thank you all.